Muy bienvenidos a todos que están en presencia. Vamos a comenzar con esta próxima sesión de Rayos contra Cáncer, que será dada por Dr. Timmerman y está con el título Considerations for Lung Saver. Estamos muy agradecidos por su presencia. Él es muy conocido en este campo acá en los Estados Unidos. Entonces es un placer tenerlo con nosotros. We're very grateful for everybody that's here for this session, this next session of Rayos contra Cáncer that will be given by Dr. Timmerman with the title Considerations for Lung Saver. And we're very grateful for his presence and with us today. And with that, I will pass the time over to you, Dr. Timmerman.
All right, thank you for inviting me to this. It's a very nice thing that's going on, and I'm really happy that you've organized the ability to sort of transmit this type of information. I like the word SABRE better than SBRT. SBRT was sort of imposed on us, the early people that were working in this realm, but the SABRE, which stands for stereotactic ablative radiotherapy, is more descriptive. And ablation is an important word that basically means to destroy, and that can be particularly an issue in these central lung tumors. So I'll try to pass on some pearls today. We'll start out with a clinical case. This is a 44-year-old female with metastatic kidney cancer. She was first diagnosed in 2013 with lung metastasis. She was treated with very modern therapy. In fact, she got dual immunotherapy with ipilimumab and nivolumab. At that time, that was experimental, and she had good response. She had to stop that due to the common side effect of multi-site inflammation in her thyroid and other organs. In 2017, she had a VATS wedge resection of lung metastasis, and I treated a few bone metastasis in her pelvis with SABRE. She then got IL-2 and later went back on that dual checkpoint inhibitors with the ipilimumab and nivolumab. Then our story moves forward to just last fall. In September of 2019, she developed new lung metastasis, and a growing lesion in the lateral left mid-lung was treated with SABRE at another institution where she lives. Then by February 2020, I saw her again. Now this time she had a recurrence at a suture line from the previous wedge resection. This is a picture of the small lesion that was treated with SABRE in September of 2019. The doctors there gave her a dose of 50 gray and 5 fractions, which was a bit higher than I would have used, but that's a reasonable dose. You can see it was a small peripheral nodule. And then in January 2020, just before I saw her again, you can see that that lesion has disappeared, and it's being replaced now by focal lung collapse atelectasis, as well as some early fibrosis at the treatment site. But unsuspected in January 2020 was that more superior, there's now a nearly obstructing lesion at the left hilum, and this is associated with the suture line. I don't know, can people see my mouse moving on the screen?
Yeah.
Okay, I'm pointing to a metal artifact here, and you can see it again on the newer image. That's a clip from her wedge resection, and so this is a suture line recurrence, and you can also see she has another new metastasis just a few months after the images for her previous treatment. So this is a very fast growing tumor, and as you can see, it's nearly obstructing the left upper lobe. And so we thought this was an urgent indication to treat with SABRE. She also started a checkpoint, and she started a TKI drug as well. But when we simulated with contrast, what we unfortunately saw was that not only did she have the large obstructing lesion, here again where my mouse is wiggling, she also had, using contrast for the simulation, a clear lymph node in the mediastinum next to the trachea and just in front of the esophagus. So this is sort of a first pearl. Whenever possible, you should definitely try to use contrast when performing simulations for SABRE, because not only will you pick up on things like this, you'll find that you can make the target smaller. In this particular patient, she had kidney cancer, and so they were trying to get by without contrast. But if at all possible, it's extremely useful to use contrast. And here's another example of what I mean. In this particular picture, it's a different patient, but we've got here a GTV and a PTV surrounding a lung tumor. And this is a small early stage lung cancer. And you'll notice from the start that while we outlined in blue the GTV, we didn't outline this tissue just lateral to it. And the reason we didn't is because it's atelectasis. The reason I know it's atelectasis is that it has a lower contrast enhancement than the tumor itself. Tumors take up contrast. Atelectasis doesn't take up contrast. And so we were able to make the target smaller. In addition, you'll notice that we didn't include this little extension off the target that has also some bright signal. The reason we didn't include that is because its signal is actually brighter than the tumor because it's a blood vessel. And again, therefore, using contrast can, even for a stage 1 lung cancer, allow you to make the target smaller and do it prudently. And so you should really try to use contrast for all your simulations. So back to our clinical case, we've got now a clinical dilemma. We've got a large hilar tumor that needs to be treated. The patient is currently breathing without any difficulty at all. We've documented that tumor is growing very quickly on CT. Certainly she'll soon have total lung obstruction. But realistically, by treating her now, I can't make her better because she's already fine. I can make her worse, but I can't make her better with this goal of trying to prevent a catastrophe. And separate from that large tumor, we have a very close mediastinal lymph node that's also growing fast. And unfortunately, the intervening tissue between the large lung mass and the lymph node is the esophagus and the main bronchus, both structures which the patient could really use. So I've made a cartoon of our situation here. So we've got two tumors. The big one I'll call T1, and the small tumor I'll call T2. This is sort of an axial cartoon. And in between, we've got the esophagus in red and the main bronchus in yellow. Now we want to give high dose to those two tumors. And in doing so, I've made this pinkish blush the high dose. But unfortunately, when you treat those two at the same time, you're inevitably going to get pretty high dose in between them. In other words, a crossfire of dose will occur right in the region of those two normal structures, and they could become impaired by this pretty high dose, again, in this situation. So sort of getting into trouble is a possibility whenever you treat in these more central regions. And a long time ago, now it's been almost 20 years, we came up with this dotted line that you might have seen before called the zone of the central bronchial tree. And basically we showed, based on the early work at Indiana, that if you treat inside the dotted line, you have a much higher risk of complications when using 3-fraction SABRE regimen than if you treated outside the dotted line. And again, this is a sort of an old concept. I think we could improve the concept by even looking at more structures, including ultracentral structure right around the main airways and in the mediastinum. near central structure we'll call zone 2, and then a zone 3 of the lung that's mostly lung parenchyma, and then finally the apical and chest wall areas. So let's first look at zone 1. This is this so-called ultracentral area, which includes the large airways, the trachea and main bronchi, the esophagus, and the great vessels, as well as the top part of the heart. So let's specifically look at these structures, what kind of structures they are, and what is their function. Because if we injure them with an ablative treatment, we have to understand whether or not the patient could tolerate that, importantly, whether they could heal. So for zone 1, we have the airways. The airways themselves in the central zone are going to be surrounded by cartilaginous rings that sort of keep them open. They're a rigid structure, very radioresistant. These airways have a mucosa, and that mucosa has a function as well. We also have the esophagus with its mucosa. We have many nerves in this region, as well as the muscle of the esophagus. And then finally, we have the great vessels, the aorta, the vena cava, the pulmonary artery and vein. And these vessels are large with thick muscular walls. What is the function then of these structures? Well, for the airways, the primary function is to allow air to get in and out of the lung, but also an important function called pulmonary toilet. I know that's a little off color, but it basically means is being able to get debris and other unwanted things in your lungs out of your lungs so they don't clog it up. The esophagus, of course, is for swallowing, the great vessels for blood flow. And all of these structures that I just mentioned are called serial functioning tissues, and it's an important distinction in that zone. In terms of radiation response to various tissues, we define tissues sort of grossly between being structurally defined and structurally undefined structures. In the case of structurally defined, it means we can sort of put a small circle around an element of it that actually does the function. So in the lung, for example, air gets finally into the alveolus and it transmits oxygen for CO2 to the capillaries, and this would be called a structurally defined tissue. That's in contrast to the esophagus, the tube that goes from your mouth to the stomach, where it's a basement membrane covered by an epithelium that has a blood supply underneath it. I can't really put a circle around what a specific function that's done along that, so it's called structurally undefined. In the way that these tissues heal after a radiation injury is important to distinguish with these two. First of all, for the structurally defined, stem cells that are residing in one alveolus, even though they're very close between alveolus A and B, stem cells cannot migrate across because there's a basement membrane in their way. They can only migrate within their own alveolus, and they're very small. So if there's injury next door, they can't help rescue that injury. And that's in contrast to the esophagus, where stem cells along the basement membrane of the esophagus can migrate potentially even fairly long distances to try to heal some sort of radiation injury that occurs. And so tissues made up of predominantly structurally defined functional subunits are called parallel functioning. They're similar to parallel electric circuits, where if you cut one limb, the whole circuit does not become dysfunctional, only the limb cut. And these tissues would include the peripheral lung, the peripheral liver, and kidneys. And they're characterized by sort of being redundant. That is, the tissue in the right side of your lung is doing exactly the same thing as the tissue on your left side of your lung. And that's in contrast to tissues made up of these structurally undefined functional subunits, which are called serial functioning tissues. Again, like an electric circuit, if you cut a series circuit, the whole circuit becomes dead. And that would include the ducts, the airways, the spinal cord, and they're characterized by a chain of function. Now, the consequences of a biologically potent dose to parallel tissues, again, like the peripheral lung, would be that toxicity is mostly volume related. And so we have metrics of toxicity like the volume that gets 20 gray or more. And for serial tissues, like the spinal cord, the toxicity is mostly dose related. So metrics like the tolerance dose, 5% at 5 years for the spinal cord. And keep in mind that every organ has both serial and parallel functioning tissues geometrically distributed throughout them. And all of the organs are connected to the body by a hilum, which is a serial functioning portion of it. Now, in terms of ablating the esophagus, again, we're still honing in on this ultracentral region. The esophagus has many sensory nerves, and so ablating the esophagus will undoubtedly cause very severe pain. Your patients won't like you if you hurt their esophagus in this way. They'll have terrible pain with swallowing. And if the radiation is circumferential, they could even develop a stricture or a narrowing of their esophagus during the healing process. So if I have a cartoon again showing the blood supply to the esophagus, it's 2 arteries on either side and arcades around. If I treat a tumor circumferentially with SABR, I could end up with a narrowing, hourglass shape called a stricture. I can, however, treat a small tumor on the side with an ablative treatment such that the stem cells on the contralateral side can come and rescue the part that I injured. This is akin to a surgical sleeve resection where they sort of shave off one side. There could be some narrowing after this, but unlikely to be a total stricture. And this is an important principle to keep in mind when we're treating next to hollow structures. Now, what about if we ablate the trachea or main bronchus? No, it does not mean that you'll get total atelectasis if you ablate the trachea or main bronchus, because they will unlikely to ever lose their lumen due to the strength of the cartilaginous rings, which are very radioresistant. The mucosa would likely denude if you treated large sections of the trachea or main bronchi, but it would eventually grow back. The thing that you can do to these structures, though, that's quite concerning, is that you could impair pulmonary toilet. That is, the ability to get rid of, or the elevator function to elevate dust, mucus, and debris out of the lungs. And that if you don't remove that debris, they can partially obstruct the lumen. And in patients who have treatment to, for example, the main bronchus, they become at significant risk for pneumonia. And the reason is shown here. And so again, a tumor near the hilum was treated with ablative radiotherapy, and subsequently there was this wedge-like collapse. But if you look in the lumen, you can see that this debris is lodged within the airway. This patient's at very significant risk for pneumonia because this is a perfect environment for bacteria to grow and cause harm to the patient. And again, this is related to the ultracentral airways. And what about ablation of the great vessels? This is the feared blowout that people talk about, where they might have massive hemoptysis, they would exsanguinate. But realistically, it's extremely unlikely, and it's particularly unlikely in the ultracentral region. I think there's a myth that people think treating the great vessels is putting people at risk for such complications. These great vessels have thick muscular walls, and if you remember from your radiobiology, a muscle is very radioresistant. And in fact, I'm still waiting to see a great vessel complication, even though people have been told to avoid these structures. Perhaps someday we'll see one. I'm thinking there could be some sort of weakening of the wall, causing, for example, an aortic aneurysm. But I've been doing this now for 20 years, and I still haven't seen that. So now let's move on to zone 2.
Dr. Timmerman?
Yes.
There's a question. So the question is, do you need functional tests like DLCO to do the SBRT?
I think they can be helpful, and I'll get to that when I get to the next zone after this one. But we did do those studies. Now, whether you need them or not, I think I can sort of tell you what happens to patients in different with different aspects of that. But let me get to that into the next zone here, because I'm sort of not quite to that level yet.
Okay.
Zone 2 is the intermediate airways. So it's not the main bronchus or trachea. These are smaller airways. They start to lose their cartilaginous rings, which already you're anticipating makes them lose their structural strength and to maintain their lumens. The vessels around them are smaller and thinner with thinner muscular walls. And the function of zone 2, again, is pulmonary toilet, primarily air distribution, which is ventilation. There's blood vessels that come through there that are going to get to the periphery. This is part of the perfusion. And these are mostly serial structures. There's also some parenchymal lung tissue in there, but mostly serial structures as well. And I'll tell you that zone 2 is the trickiest part to treat, and it's actually the most risky for causing serious complication in our patients. And I don't think we've probably characterized this as well as we should to understand that. It's a very vulnerable serial structures because the airway lumens are small. It's hard to not just completely circumferentially treat these airways, and therefore there's going to be a high probability that they'll collapse. And they'll have a less ability to repair because they don't have cartilage to prop them open. Vessels there have thinner walls. I have seen patients die of massive hemoptysis, and this is where the vessels bleed, not in the great vessels. They bleed in these intermediate vessels in this region. And primarily this happens when tumor invades them because it weakens their wall, but then the radiation treatment makes it difficult for them to heal. So for zone 2, for example, if I treat these airways are going to be branching out more and more, just like a tree or a bush goes from the trunk to the main branches and limbs, then to smaller and smaller branches and twigs. This is the same thing that's happening here. If you treat a tumor in this location, we don't see pneumonia necessarily because we're almost having a sterile environment this far out, but you will get this atelectasis of the segments that are involved, and they'll prune and pucker up all the way out to the periphery of the lung. And your radiology colleagues need to be able to recognize this as a complication of SABR. So now we'll move to zone 3, related to the question about ventilation and perfusion. Zone 3 is a web of very small airways that end up in the alveoli and capillary complexes. The function of zone 3 is to do respiration, that is, exchange oxygen for CO2. And ideally, zone 3 will allow a match of ventilation and perfusion. And indeed, SABR treatments, both the high dose and intermediate dose in these regions, will cause some perturbation of a matched ventilation and perfusion. Often this will recover afterwards, but in the early studies that were done, indeed, patients did have impairment of ventilation and perfusion. These patients, by the way, were very frail and very pulmonary impaired, and otherwise they would have had surgery. This was early stage lung cancer. They tolerated the therapy despite very impaired ventilation and perfusion in pulmonary function tests. And so I wouldn't say that checking these things would stop you from doing these treatments, but it is true that radiotherapy does impair both ventilation and perfusion. And fortunately, this is a parallel functioning organ and not a serial functioning organ. And so for zone 3, it's all about volume. Very low doses of radiation will totally disable parallel tissues like lung, and probably only takes about 15 to 20 gray total dose. That tissues that are exposed to those dose ranges of SABR, that lung probably no longer functions. And the intermediate dose will destroy the lung's function as well. So it turns out we're all born with much more of this parallel tissue than we need. In fact, we only need about 1/3 of our native parallel organ volume. Native means the amount of tissue that you had when you, let's say you were in your prime right after puberty or something like that. And this rule of 1/3 applies to lung, liver, and kidney as well. And everything beyond a third is a reserve. In other words, you're born with more than you need. And that's why we can see destruction of a fairly large amount of it. For example, surgeons will remove up to 2/3 of a person's liver if they're trying to remove metastasis. If they remove more than that, though, the patient starts to have liver dysfunction. And so 1/3 of the liver is called the critical volume. And then the question is what is the threshold dose that damages the critical volume? And for lung, it appears to be in the 15 to 20 gray range. And so any lung that gets 15 or 20 gray could be damaged. And more importantly, any lung that gets less than 15 to 20 gray will not be damaged. And that includes V5. So I may hurt people's feelings, but V5 is an irrelevant metric to be worried about when doing lung saber. I also think that's true of conventional radiation as well. It's below the threshold dose for injury, and so I think you're wasting your time and effort trying to reduce V5. So the final zone is zone 4, which is the apex and chest wall areas. The structures include lung, bone, and nerves. We got the brachial plexus and intercostal nerves. And the function of this zone is, again, ventilation and perfusion, conducting electricity in the nerves, and this is both a serial and a parallel functioning zone. So with the chest wall, we have a trade-off, and I know that you've heard about people having chest wall injuries related to SABR, and the question is whether you should try to avoid that or not. I am careful around the brachial plexus, and I try pretty hard with IMRT to meet the constraints that we've published for the brachial plexus. Sometimes I do exceed them, though, while I'll never exceed the constraints for the spinal cord. And moving down to the chest wall, the ribs and intercostal nerves, there's sort of 2 potential injuries that we could be causing with SABR. One is that radiation is known to cause a focal osteoporosis, that is a mismatch between cells that build bone versus cells that tear down bone, the osteoblasts and the osteoclasts, resulting in a weakness of the bone right where we irradiate. And the rib then could fracture in that location. This would be painful, either due to the nerves in the periosteum or actual bending of the rib causing intercostal nerve pain. This kind of pain eventually heals, and the rib fractures heal. And the other possibility is that we're causing just direct nerve injury to the intercostal nerve, which is a serial functioning structure. So the dilemma is, if you contour and then try to spare the chest wall, where does the dose go? That is, if you don't put it in the chest wall, where are you putting it? And the answer is you're putting it into the lung, which is not so good. You end up getting more fibrosis, loss of function, both of which could be bad in the long term for these patients with pulmonary disabilities. In my own experience, for years I tried to spare the chest wall, and I would still have chest wall problems and pain. And so in my current mindset, I don't even try to spare the chest wall. I just try to make the dose fall off in all directions as fast as I can. 20% of the patients, 10 to 20%, are going to have rib fractures or chest wall pain, and I just try to nurse them through that, so I no longer try to spare the chest wall. So let's get back to our clinical case that we started with. I'm sorry?
Dr. Timmerman, there was a kind of a second part to that question, which I think you kind of talked about it a little bit, but for patients who already have, say, pulmonary fibrosis or EPOC, what are your considerations, or how do you deal with those?
Well, again, the majority of patients treated on the clinical trials were absolute pulmonary cripples. There are some fibrosing problems that are made dramatically worse by any form of radiation, SABR or conventional. So those patients with that idiopathic pulmonary fibrosis, for example, I would try really hard not to treat those patients. But patients with typical emphysema or any sort of COPD, I think that these are the exact patients that we treated in all these experiences. And so we've treated patients with FEV1s of 15% predicted. Again, I think there's a risk, but these patients tolerated it, and there's no way they would have tolerated surgery. The other option would be to just not treat them at all. But in 2 case series of surveillance-only treatment for people with poor pulmonary problems and lung cancer, most of those patients died of lung cancer, not COPD. So to not treat them puts them at great risk as well.
Right. Also, what are your constraints for the brachial plexus?
I'm not very clever, so off the top of my head, I can't remember constraints very well, but I can share with you all of my constraints that I've put together with the help of a lot of people, and we can distribute them to the group. A lot of people use them in the US for their treatment planning. I'm sorry, I don't remember them off the top of my head. I just don't have room in my brain for that kind of stuff.
Yeah, if you get those to us, we'll distribute.
You can distribute them, and they'll be different. So the numbers will be different depending on the number of fractions. And so if you use 1 fraction, it's going to be different than if you use 5 fractions, just as you'd expect. All right, let's get back to our clinical case then. So remember, we had 2 very central tumors, one which was massive. There was a difficult overlap area. The patient needed urgent treatment. And so we did a simulation which included a 4D acquisition. Remember again, the 0% phase is inspiration, the 50% phase is expiration on these 4D scans. You can do some numerical editing to get the highest Hounsfield number for every location on the CT couch, which is called the maximum intensity projection. It sort of smears the 0 and the 50% together. And then you can even do an average intensity projection, which is what we use for treatment planning. And I'll just tell you, when we simulated this patient with this large hilar tumor, the tumor didn't move very much in the superior inferior direction, which is usually the biggest motion. Instead, it just sort of moved front to back in the axial plane. So here's the tumor, the hilar tumor anyway, outlined on the 0 phase. And you can see it's a very large tumor, and the contrast helps differentiate large vessels in the vicinity from the tumor itself. And here it is on the 50% phase, and it's not much different in terms of going up and down. And yet, front to back, it did move a fair amount. And so the ITV, or internal target volume, is laid out here on the average intensity projection, which is what we use for treatment planning. And you can see it's larger. If I showed you the pulmonary windows, you'd see how it's smeared front to back. But here's the ITV then. This is where the gross tumor can be throughout the respiratory cycle. And then we add in the normal structures, here's the other, first I'll say here's the other tumor, which is right in front of the esophagus and next to the large hilar tumor. And now we add the esophagus, the airways next to these targets. This is the trachea, the right mainstem bronchus. This is the esophagus. And then on the right, when we add the PTVs, that is the extension for setup air, now we've got overlap with the esophagus and overlap with the airway. So what do you do when your targets are abutting a serial structure? Remember, serial structures, if you damage them, they can be a catastrophic damage. And so here we've got a PTV overlapping the esophagus on this cartoon. And what I would advise you do is make a substructure of the esophagus in this case that's not in the overlap region. In other words, make a substructure that's got some separation from the PTV. So you've got structure A, it's outside the PTV, structure B, which is inside the PTV, and then you use IMRT in substructure A. You try to strictly meet organ limits using IMRT, but in structure B, all you do is avoid a hotspot, no more than 90% of the scriptose in structure B, and that way you'll have an achievable dose constraint rule set for your treatment planning algorithm. If you were to tell it to give full dose to the PTV here, and avoid the esophagus to the esophageal constraint. That's an impossibility. And when you ask a computer algorithm to do something impossible, it won't give you the best results. By the way, what I just said does not apply to the spinal cord. So in terms of planning priorities, then you have to decide what's most important, what's least important. And for SABRE, the constraints that we've used, as well as the RTOG trials, is to, number one, never overdose the spinal cord. Number two, cover the target conformally with the prescription dose. That's the essence of SBRT or SABRE. Next, create compactness of dose, that is, have the dose fall off in all directions in a real steep fashion. And then finally, respect normal tissue constraints other than the spinal cord. And so this seems kind of odd to classically trained radiation oncologists that we wouldn't put respecting normal tissue constraints number one. We did for the spinal cord, but not for the others. And the answer is that other structures, if properly treated, if the dosimetry is properly conducted, have the ability to heal. And every time a surgeon operates on a patient, they injure that patient's body, but it heals. And now that we're armed with this very impressive and very potent therapy called SABRE, we can use that same healing property. And as long as we give the patient the opportunity to heal, they'll have potentially good outcomes and tumor control. Another thing I want to point out is sort of a difference in a dose volume and histogram interpretation for normal structures. Usually when you look at a dose volume histogram, for example, I'm looking at the 15 gray dose here. The volume between this line and this line is the volume that gets at least 15 gray, that is 15 gray or more. This is an important way to consider it for serial functioning tissues, but for parallel functioning tissues, we need to do it the opposite way. We need to be more concerned not about what tissue gets radiated to a high dose, but how much tissue is spared a certain dose. Because remember, the tissue that is spared the threshold dose is the tissue that you have then to perform organ function. Tissues that get higher than the threshold dose are ruined, and that's not the issue. So this is the volume that is spared 15 gray or more, and that's how we calculate critical volumes, because critical volumes for parallel tissues must be preserved. You avoid the toxic threshold dose, leaving the patient with enough organ function to survive. Don't forget, however, that tissue must be connected to the body through the hilum. Surgeons understand this. And again, if we use these tools, we have to start looking at where the dose is, not just did we look at the dose volume histogram. And then in terms of central tumors, how can we avoid the serial damage of central tumors? In RTOG 0813 that Andrea Bezjak published, they treated primary lung cancer. Lung cancer needs a quite potent dose, so they went to very high doses in this trial. And the way they tried to avoid toxicity was to use 5 fractions instead of 3. We used 3 fractions at Indiana in the early work that showed the toxicity, and they tried to use 5 fractions and were able to get to quite high doses. Another way to avoid toxicity is not use so much dose. And for kidney cancer, it's interesting. Kidney cancer is, in the context of SABRE, one of the most radiosensitive histologies that we treat. And so we lower our dose when treating kidney cancer compared to, for example, lung cancer. So these equivalent doses are used at UT Southwestern, 40 gray in 5, 36 gray in 3, 24 gray in 1. And of course, those lower doses will reduce toxicity. We, of course, use IMRT to avoid dose to the serial structures and try to avoid circumferential radiation. And then finally, I'll talk a little bit later about a concept called pulsar that we're using now to also reduce toxicity.
Dr.
So
Timmerman?
Yes.
A question actually came in specifically about RTOG 0813. And the question is, there is a cartoon that shows a PTV and OAR overlapping, allowed to prescribe to the 80% isodose line. Maybe could you please give us some insights about it?
This figure here? There wasn't any figure.
Is it the cartoon in here? Or is it? It's in.
Maybe in the protocol.
David, maybe you can elaborate.
Yeah, by chance. Yeah, it's in the protocol, if you by chance remember that.
I don't remember the 80% thing, but in the protocol it said that the PTV should receive, excuse me, I'm going to start over. 95% of the PTV volume should receive the prescription dose, which means that 5% doesn't have to receive the prescription dose. And in that protocol, it said that that 5% must get at least 90% of the prescription dose. I think that's what you're referring to. And that's where this figure, this cartoon, is also using the same idea. That is, if you're allowed to have a part of the PTV underdosed to 90% of the prescription dose, then put that in the organ at risk. In other words, don't let it be on the contralateral side. Put it where you could spare some, improve some healing by putting that lower dose into the organ at risk. And I think that's what you're talking about. I'm not aware of any 80% rule in that protocol.
Thank you.
Okay. So here's the Imrt plan that we ended up using. First of all, it was a fairly large number of arcs. There's big axial arcs. There's even some sagittal arcs and other small non-coplanar arcs. Again, why are we doing this? We're trying to make the dose fall off more isotropically in all directions. And if we look at the isodoses itself, the prescription, the patient came from a great distance, so we ended up using 3 fractions instead of 5. I think if they were local, we'd probably have used 5. So we used 36 gray and 3 fractions, but these treatments were separated by 3 weeks, which is the pulsar concept that I'll talk about in a second. But if you look at this dose distribution, we weren't able to stop the coalescing of high dose in between the 2 targets. And this was despite great effort to try to avoid that. What we did do, though, is to try to push it as far forward into the great vessels and away from the airway as we could. Again, I've told you that I don't sort of agree with the notion that the great vessels need to be so avoided, but I do agree that the bronchus needs to be avoided. And so we prioritize the bronchus over the great vessels in this composite dose distribution. Now, pulsar. Pulsar is a split course, and from 1970 to 1990, there were a whole bunch of protocols studying the notion of a split course, that is, putting a break in between a cluster of fractions in the middle of the treatment. The goal of the split course was specifically to reduce toxicity. And so, for example, a patient who would, instead of would have gotten 40 gray and 20 fractions in 4 weeks, would get 20 gray and 10 fractions, followed by a 2-week break, followed by completing the course 20 gray and 10 fractions. And the whole idea was to reduce toxicity. And indeed, it did reduce toxicity. There was less toxicity with a split course. Unfortunately, the tumor also liked the split course. And so tumors started to proliferate during the split course. And therefore, it was called a tumor control penalty with a split course. That is, if you put any break in the middle of therapy. And this idea has been well known even for any sort of unanticipated breaks, like in head and neck cancer and cervical cancer. Getting the treatment done as fast as possible is associated with better outcome. Now keep that in mind, this idea of a split course and how it didn't work with conventionally fractionated radiotherapy. But the hottest thing going right now in radiotherapy is adaptation. And we've got opportunities now to buy fancy MR Linacs and other sort of high-tech linear accelerators that can treat a patient, re-image, and then replan to adapt the therapy. And adaptation means respond to change or respond to new information. And I took this picture off the internet, and it shows how a patient's tumor, in this case a head and neck tumor, shrunk to the point where after the treatment shrinkage, the skin now is getting overdosed using the plan that was designed at the beginning of therapy. In other words, as the tumor shrinks, organs at risk will move into irradiated zones that were designed for tumors. Now, you and I can probably agree that there's an obvious Achilles heel of adaptive radiotherapy, And that is, with conventional radiotherapy, at least 2 gray per fraction, nothing changes. Conventional radiotherapy is all about these tiny little nudges of DNA damage that are better tolerated by normal tissue than tumors. And the whole point of conventional radiotherapy is you don't want significant changes, particularly toxicity. So I always laugh to give the example of, this is Jennifer Aniston at age 20. This is Jennifer Aniston at age 50. And as you can see, there's no change, and so it would be very difficult to adapt to Jennifer Aniston. Now, what about SABR in a split course? I've already told you that conventional radiotherapy in a split course had a tumor control penalty. Well, first of all, does it reduce toxicity? And there's already some evidence that every other day is less toxic than every day in prostate cancer. Does it avoid the tumor control penalty? SABR is so much more potent than conventional radiotherapy that it's very unlikely that in the period of weeks to probably even over a month that there'll be a tumor control penalty. And indeed, many of you probably use 8-gray-in-1 for bone metastasis, and I would think you'd be hard-pressed to show that 8-gray-in-1 ends up with tumor progression in a period of weeks. In fact, it's a standard therapy for bone mets. So there's good reason to think that split course SABR would not have a tumor control penalty, and certainly will have less toxicity. So a split course SABR also facilitates adaptation, which is what we were just discussing with these MR-Linacs, that is, change from one treatment to another. SABR is a very dramatic dose. The tumor undergoes an upheaval. The immune system comes charging in. And so it's an opportunity to adapt. So you'll see tumor shrinkage better than with any other therapy using SABR. And tumor features will change, allowing us to adapt to them as well. And microenvironment will change as well. Again, a lot of opportunities for adaptation. So this new concept of radiotherapy is called pulsar. So we're going to abandon the notion of fractions. We're instead going to use pulses of radiation separated by time. And one pulse would be given, then isolated from another by at least 7 days, but probably often more, even weeks and months. That large of separation in time between fractions we're calling ultrafractionation. And with the ultrafractionation, pulsar is poised to be more personalized and optimized. And so for our clinical case, we had a central tumor, a high risk for toxicity. We used IMRT to avoid the serial structures, as I showed you. And we used pulsar simply to reduce toxicity. The split course is less toxic and perhaps an opportunity to adapt. So for Pulse 1, this is what happened. We had a 12-gray dose. This was the PTV around the ITV. This was the cone beam on the machine on day 1. You can see it's a very large tumor. We gave the 12-gray and waited 3 weeks. Patient came in for Pulse 2, had no complaints of any problems. And this was the cone beam for Pulse 2. So a rather dramatic response. This is the treatment plan. Here's Pulse 2, dramatically different, to the point where it really made sense now to replan this case for the much, much smaller volume. So that's what we did. We replanned, and you can see the initial plan and then the much, much smaller volumes of the final, Pulse 2 plan, and gave her the second pulse. This time with adaptation. On Pulse 3, unfortunately, there wasn't as much response, so we didn't need to replan it for Pulse 3, but overall, she tolerated the therapy very well. So I think that these are options to consider to try to avoid normal tissue toxicity when treating these difficult central tumors. And if there's any time, I can take some questions or whatever you want to do with the remainder of the hour.
Great. Thank you very, very much, Dr. Timmerman. That was incredibly insightful. Wow. So there are a few questions. There is a question about if you could give any comments on the maximum dose allowed to use per fraction in combination with immunotherapies.
Thinking about the protocols that have been done, most of them are just using doses of SABR that were used without immunotherapy. Whether they're optimized or not, I don't know. But I know that, for example, the Radvax trial used 20 gray per fraction, which is a lot. Now, Sandra DiMario and her colleagues, Silvia Fermenti, looked at the specific animal models in mice and found that TREX pathways might be stimulated by giving doses of over 8 gray in combination with immunotherapy, sort of abrogating the immune effects that would have been otherwise synergistic. That's been only in one mouse model, though, so I don't think that we should conclude from that you shouldn't give over 8 gray. I've personally seen really dramatic effects at a variety of doses. I bet there is a better dose, but I'm afraid to say we don't know what it is yet.
Okay. Another question is, what about the interplay effect? Is it important for VMAT? Can it be avoided? Is it enough to just use a 4D scan at simulation?
Okay, I'm not familiar with the term interplay effect in that context.
It might have been in context of the pulsar by chance.
Oh,
If that's correct, Juan. You want to maybe clarify?
Juan, you can put your microphone and speak.
Oh, he's talking in general.
okay. Maybe repeat it again and I'll catch it this time.
So he's asking about the interplay effect. I'm not sure. I'm a physicist, so I'm not sure about the interplay effect either. But is it important for VMAT?
So VMAT and Imrt, in my opinion, are the same thing. It's just a different way to do Imrt. All of these Imrt techniques are threatened by motion, in that when you look at a treatment plan with Imrt, you're looking at a freeze frame situation, whereas in real life, things are moving somewhat. And so the RTOG recommended that motion shouldn't be more than 5 millimeters if you use Imrt. And that's probably especially true if it's small targets. Now, for large targets, like the case that I showed you, many of these things get washed out.
Mm-hmm.
And so I would definitely use Imrt for cases like I was showing you, because otherwise you're just going to have so much more dose in between structures. You won't be able to create the concavities that you need. And most of the patients treated on 0813 got Imrt.
Right. I actually have a question. In terms of the pulsar that you were presenting on, how much has there been much like clinical publications about this?
No, and in the main areas of interest for pulsar, I didn't go into it at all, but it's related to immunotherapy. That is, that the timing of immunotherapy in conjunction with radiation may be way better optimized with pulsar than with the way we currently do, say, SBRT or SABR. That said, we have at least 5 protocols ongoing now in brain mets, bone mets, primary lung cancer, GBM, with pulsar as an immune modulator. The reason I'm using it in this case is simply to reduce toxicity in a patient who's otherwise at very high risk for toxicity. I think that we've already proven as a profession that split courses are less toxic. So in this context, we used it for, in my opinion, a well-validated reason to reduce toxicity, and also gave us this opportunity to adapt that turned out to be very much in our favor.
Okay.
Dr. Timmerman, if I may, this is fascinating. And speaking from UCSF, there are a few things here that I think I'm learning, having finished my long SBRT rotation. And I think there's one point that you brought up that is essential, and that is when we're thinking about SABR, it's not the same as conventional radiation. And the way we approach a case maybe is a little different and maybe a little bit more akin to how you might approach a surgery. And in terms of thinking like, okay, you know, I'm going to have to hurt some tissues, which ones can recover eventually versus which ones can't.
Yeah, that's if you really want to take SABRE to the next level, that's what you have to do. You have to accept some injury risk. In fact, accept that there will be injury. If you give an ablative dose and your tumor is touching the esophagus, you will injure the esophagus. Now, you could either decide not to do it at all, or you could start to think about how does the esophagus repair injury, and to what extent can the esophagus repair injury? And like you said, this is exactly how surgeons always think. They always know that they're going to injure the tissue, and they always try to create a circumstances in which it will be very likely to heal after a period of recovery. And I think radiation oncologists and physicists and dosimetrists have to start thinking this way and not just sort of blindly try to meet some dose constraint that precludes any injury. Otherwise, you'll never achieve the potential of this therapy that it could achieve in curing cancer.
Mm-hmm. And I think one takeaway that I'm going to think about is for chest wall, for instance. We have a lot of peripheral tumors, and our standard practice is to contour the chest wall and, you know, put constraints. But if you think about it, you know, that can recover. But if you dump the dose into the lung, that's not going to recover.
That's right. Yeah. Plus, I still think you'll have chest wall problems. I mean, I did all this years ago, and it just it seemed like it was a exercise of several years that led me nowhere.
Mm-hmm. Yeah, and this is so helpful for so many of the people on the call. As you can see, you know, people have read protocols, they've read the documents, but hungry for the chance to talk to the people who are thinking about these things. David Martinez actually has shown me the figure that he was referring to in the 0813 protocol. And David, I don't know if you want to share your screen and maybe ask the question that you had. Maybe some others also have it.
I stopped sharing mine so that he could share it.
Okay, excellent.
Dr. Timmerman, many thanks for your wonderful lecture. It's an honor to be here and sharing with you this lecture. I was referring to this image in the 0813 protocol.
Oh, okay. Yeah, I actually drew this figure. This was, now, in this situation, when I was referring to the prescription isodose 80%, that's referring to, in the plan that's normalized to a point, what were the allowed isodose lines that you could prescribe the full dose to. And so what you're effectively going to do is renormalize the entire plan. And so this figure, we allowed in that protocol people to prescribe between 60 to 80% isodose line to give the prescription dose. And so in this case, they were trying to convey that if you prescribe to the 80% line, and you didn't have to, but if you did, then it was the same concept as I was showing. And I think it was confusing enough that I redid the figure to the one that I showed you in my presentation. So this is the exact same idea as what I tried to show you in my figure on my presentation.
I thought those figures looked familiar.
Okay, thanks.
Yeah, and I drew them both. It's just that this attempt was not as good as my next attempt. Sorry about that.
Many thanks, Dr. Timmerman.
And I think
I'm sorry.
No, continue.
About the relation of the dose fall-off between the dose fall-off and the volume of the PTV.
What about the relationship?
Dose fall-off and the relationship with the PTV volume.
Oh, yeah. So we gave a number of milestones that we tried to get people to to use, and these are called compactness criteria. Compactness, like being very fast falling off from the edge of the target into the normal tissues. And there were two compactness criteria. One was called the D2CM, which was the dose anywhere in the plan, the highest dose anywhere in the plan that's 2 centimeters away from the PTV in any direction. And so the protocol required it to be under a certain amount. And then the other one was a conformality ratio of half the dose, and we called it the R50. And this one's no different than the typical conformality ratio, which is usually the volume of the prescription dose to the volume of the target. This time it was the volume of the 50% of the prescription dose to the volume of the target. The smaller it was, the better. And if it was under a certain amount, it was considered adequate. Now, these were done in the original RTOG 0236 protocol and then updated for this protocol to try to give other sites targets to make good plans. In the original Indiana experience, there were no constraints, there were no guidelines. We just made plans that we thought were as good as we could do. But when you took it to a protocol, you had to come up with these ideas. And often what they were trying to do is avoid like giving just a APPPA field, that is a field from the front and a field from the back, and then prescribing high doses. We didn't want people to do that. And so these criteria of compactness made it to where the site would fail the quality assurance test if they didn't meet these criteria.
Okay, good. Doctor, and another question, sorry if I bother you about I would like to know about the follow-up of the patients that are committed to do SBRT, the radiologist colleagues, because the SBRT makes some different reactions in the lung from normal radiation treatments. So
yeah.
As we know, there are some high-risk features that we can see over the CT scans in the time of follow-up. How was your experience or your department experience trying to teach our radiologist colleagues about these features?
Well, it takes a long time, and initially your colleagues in radiology will basically be saying that everybody has a tumor recurrence because they'll decide that all the dense fibrosis and wedge-like collapse will be consistent with tumor recurrence. What you can do, though, is go over those films with them starting at 3 months. At 3 months, you're unlikely to have very much atelectasis or wedge-like collapse or even fibrosis. The tumor will shrink a lot. You'll keep track of where that is. And then in 6 months, when more of that consolidation sets in, you can go back and track it and see where the tumor is relative to this collapse. And eventually the radiologist will understand that they need to really look for pulmonary markings that lead them to understand the difference. Now, that said, the other criteria that we used early on was PET scan. That is, we did PET scans before the treatment, and if the patient had consolidative changes but without PET avidity, we said that it wasn't tumor, and vice versa if it was PET avid. Finally, David Palma and others did a very nice analysis of CT changes after SABRE that included a whole bunch of criteria that would be very familiar to a radiologist. And if you could print out that article about CT changes after SABRE, and then you could just give that article to the radiologist, I think they would appreciate that.
Dr. Timmerman, a question from one of the participants would be, if you can add any insights on why some tumors are quickly responding to SBRT and others not. Is there a typical pattern that they can follow in the radiological response? Do they have a typical pattern?
Yeah. Again, in the lung, if that's what we're talking about,
Yeah.
you have a timing effect where early on the tumors will often shrink prior to this onset of atelectasis becoming fibrosis. So you've got about 3 to 6 months for that changes. Now the patient I showed in the example, I think is interesting because when a tumor shrinks, of course, radiation doesn't shrink a tumor. The tumor has to shrink by cell loss factors. And some of those cell loss factors can be sloughing, exfoliation. So, for example, the tumor may slough cells into the airway and the patient coughs them out. That would shrink the tumor. But for tumors that are so into the substance of the lung, that's not very likely. So the most likely cell loss in this case was from phagocytosis. That is, the patient's own immune system came in and gobbled up dead and dying tumor debris and carried it away in neutrophils and macrophages, etc. This is partly why I like pulsar, because if we would have given the treatments on consecutive days or even every other day, we would have killed those cells that otherwise would have come in and done the phagocytosis that would have afforded a tumor response. So with pulsar, you see these really dramatic tumor responses simply because we're not giving the next pulse yet. And this might also improve the possibility of having an adaptive immune response that could be even affording an abscopal response. So I think we've got a lot to learn about this. Giving the treatment all at once may not be the best way to do it. And we might be able to see much better responses if we use the pulsar approach.
Yeah.
And Juan Perry asked, do you think there's enough evidence for us as radiation oncologists to believe that higher dose induces abscopal effect?
The abscopal effect is really impressive when you see it, but you'll only see it a few times in your entire career at this rate. And so we've got to figure out a way to make the abscopal effect reliable and common. There's already some pretty good evidence using IL-2 and SABR that you can increase the response rate over IL-2 alone, and that would be a clinical trial confirmation of the abscopal effect. But it still needs to be much higher. We need to learn a lot more about other therapies. For example, in lung cancer, they're still giving people chemotherapy, and which really saddens me because there's nothing harder on the immune system than chemotherapy. But the bottom line is that if you can participate in these trials that look at dose, sequencing, things like pulsar, I think all of these need to be systematically studied so that we can find a way to make a systemic response afforded by a local therapy. And everybody's talking about it, but it isn't any further today than it was, 5 years ago. And it's because we just haven't done thoughtful clinical trials to really tease out these effects.
So
It says thank you.
from the previous question that I had just asked, have you ever seen pseudo-progression in lung SBRT or in other parts like the liver, post-SBRT?
I've seen pseudoprogression rather commonly now in combination with tyrosine kinase inhibitors. And what I mean by pseudoprogression is that we've had patients who had a good response to SABR and then either concurrently or later got put on a TKI, tyrosine kinase inhibitor, small molecule therapy, and then all of a sudden the treatment site flares up in an angry reaction, inflammatory reaction that is often confused with tumor progression. In those circumstances, the worst thing you could do is give more radiation. So it really behooves you to even biopsy it if you have to before you would ever embark on a retreatment, because there's nothing worse for pseudoprogression than more radiation.
Very interesting. Wow. Okay.
Well,
I think we've come to just about, I think that's almost all the questions. We
yeah.
missed Ben?
No, I mean, I think we could stay here all night. There's
Right.
so much interest. You know, what you have done for the field is amazing. You know, in being innovative and thinking outside the box, and now other people are, you know, learning more and studying for the use of Sabre in Latin America. You know, there's a lot of interest to try to learn this, to try to adopt it, and then maybe in the future also study it, and we can all advance together in this.
Well, you're very kind, and I'm very impressed with what you're doing collectively with the people on the call, because I think that one of the things that's really hard on patients is to come every day for so many treatments. There's many parts of the world, even within the United States, where coming for 30 treatments is just devastating for their livelihood. And so if we can all work together to at least make treatments somewhat more convenient, I think that by itself could really make a difference. And then if we could, in the meantime, find a therapy that's on par with surgery, then we've got something, because surgery cures so many more patients than radiotherapy currently, but I think we could take them on.
Excellent. Well, we have recorded this session. I think a lot of people are interested in rewatching this. Thank you so much for sharing the articles and the slides too. Michael, I'll let you close if you have any concluding thoughts.
No, I actually, you echoed the thoughts that I had earlier, Ben, that, you know, looking at Sabre and as more of like a surgery, in which case you have to really take into account the tissues that you're you're ablating and their properties and what is also dependent on them. That's something that's a paradigm that I've never even considered. So that was fascinating to hear about, and then actually kind of change my train of thought. That was very, very enlightening, I would say. Maybe one little question that kind of just came to me briefly for you, Dr. Timmerman, is in terms of the expanded use of Sabre, what new technique or technology do you think is needed to better expand its use? Would it be better imaging on that front, perhaps?
Most of the way we were able to take it to the next level was based on improved technologies, and so we're always looking for better technologies. But from a biological point of view, what we desperately need is radioprotectors. That is, some way to protect normal tissues that are serial functioning from the ablative dose. And there was a time when the field studied protectors, but they all fell out of their patent protection, so there's no one probably going to study them anymore. There's a few out, but something so simple as like this hydrogel spacer that is used in prostate cancer basically almost eliminates high-grade rectal toxicity and allows people to get, you know, potent treatments for their prostate cancer. It's a protection issue, so it's a different mindset than for decades all we cared about were radiosensitizers. What we really need are radioprotectors.
Right. Great. Well, well, with that, I think we can come to an end. Dr. Timmerman, thank you so very much for everything that you shared with us. It's been an incredible lecture. Thank you very much. And también queremos agradecer a todos que están participando con esta lectura por su presencia. Y última vez queremos avisarle que este sábado vamos a tener una sesión en que vamos a hablar en cuanto a COVID-19 y lo que están haciendo los clínicos para. And with that, I think we'll come to an end. Thank you very much once again, Dr. Timmerman.
You're welcome. Thank you.
Thanks, Deb. Thank you so much. Stay safe, everyone.
Yes. Be careful.
We'll send out information about this Saturday.